All right, good morning, everyone. Thank you for joining us. Today, we're very fortunate to have our, actually was the visiting professor for the Heart Center also join us here for surgical grand rounds. And I want you to help me welcome Robert Jaquiss. He's a professor of surgery and the Albert O. Nichols Endowed Chair in Cardiac Surgery at Children's Wisconsin. He is also the co-director of the HERMA Heart Institute. I could go through the whole CV, but probably need another hour and a half. But I will tell you that he started his career in programs in Florida, early career in Florida and Wisconsin. Eventually, he moved on to lead the program in Arkansas, then Duke, then UT Southwestern in Dallas, and now 20 years later, back in Wisconsin. He's got over 200 publications, again, ranging everything. But I will tell you a little personal comment. I mean, I've gotten to know Jake more over the past, I say, 5-6 years, collaborating in leadership venues and different events. And what I admire about him, despite all the talks I've heard him, give throughout the years, his ability to share information and experiences freely, not just advice on the good outcomes, but also advice on the things that he's learned throughout the years. And I think yesterday is a testament that he will share that with anybody at any level, all the way from, superstars in the field to younger residents and fellows. So I am the beneficiary of some of those pearls you have thrown out throughout the years. So thank you. Lastly, I want to share that he's the president. He's the 11th president. We just figured out the number of presidents of the Congenital Heart Surgeon Society. And they are, and we're going to steal his thunder, but they're starting an effort to certify programs and basically make sure that congenital programs have the minimum requirements to provide best care for children. So please, again, help me welcome Jake, and we're going to have his talk on reducing the chaos in congenital surgery.
Well, good morning, and Dan, thanks very much for both the introduction and the invitation to get away from frigid Milwaukee. When I got off the plane, I took a snapshot of the local Apple weather, which was 109, and I took a snapshot of my home, which was 69. So it was quite dramatic. And it's also good to see several old friends from various times in the past, ranging from Steve Zangwill from 20 years ago in Milwaukee to Josh from just a few years ago in Dallas and others. So the title of my talk is called Reducing Chaos in Congenital Heart Care. Some of the people in the room will know about this chaos because we live in it. Some people may have heard about it. Some people may not. I'm going to try to avoid making political commentary today, but some of those of you in the room who may be liberal and read the rag, the New York Times, tongue in cheek, may have heard about it by reading a front page story in the New York Times. But we have a chaotic way of delivering heart care for children in the United States. But it's not unique to us. So the topic that I'm going to talk about sort of first came to my consciousness about 25 or 30 years ago in two parts of the still standing British Empire. The first of these was from Bristol in the United Kingdom at the Royal Infirmary. And a comedy magazine there called Private Eye had an article which was written by a guy who's both a comedian and a physician, the only one that I've ever heard of, actually. I've heard some of us think we're funny, others are funny without intending to, but intending to be. But he wrote an article which was called "The Killing Fields" to describe the operating rooms for children getting congenital heart surgery, and the ward that they were housed in was called the departure lounge. This is horrible if you think about it. Even if you don't think about it, it's horrible. But eventually, this made its way into the newspaper, and there was a big hue and cry and a lot of pearl clutching. And some things that happened after that. And almost at exactly the same time, another part of the British Empire in Manitoba, specifically in Winnipeg, there was an almost identical circumstance. And what was happening was that cardiac surgery units were delivering care which was substantially substandard, but allowed to persist for a long period of time. And substandard care and congenital heart care is associated with morbidity, certainly, but also excess mortality. This was a fairly horrible circumstance in two quite distant places. In the United Kingdom, there was an assemblage of people led by a prominent jurist who wrote a long, detailed, painful report called "Learning from Bristol," and the sequence of events that led up to the Kennedy report is outlined on the right. But this took forever, years and years and years, millions of dollars, hundreds of thousands of pages of transcript to describe the performance or substandard performance in a congenital cardiac unit. At the same time, this was also going on in Canada. In the United Kingdom, what was decided was that they needed to be more organized. They needed to report their data transparently. There needed to be standards set for how performance was carried out, how it was measured, how it was audited. And as a result of that, in the United Kingdom, every year a report like this, which is publicly available, I downloaded this last night relatively late, that describes the performance of the centers in the United Kingdom under the auspices of the National Health Service that are delivering cardiac care. And as a result of that, this is the unadjusted 30-day surgical mortality for kids under 18. And the most recent year was less than or approaching 1%, and over a 10-year average, 1.5%. In context, in the United States, our aggregated reports that some of us know very well is about 2.5%, sometimes 2.7%. So they figured something out in response to this fairly dismal start. This is a publicly listed, easily accessible, tabular presentation of the performance of the centers in the UK and Ireland that are delivering heart care. And if you focus on the line that says actual survival, the overall survival is 98.7%, which is astonishingly good. But that's consistent across all centers. There's very little variation. If you look, the lowest survival rate that I see there is 98.0. So the terrible performers have a 2% mortality rate and several much better than that. So there's a tight scattering of the point estimate of performance, which is the dot in the middle. And importantly, every one of them is performing at least as they should be or better. No one is performing worse. It's a little bit like Lake Wobegon, where all the children are above average. So at the same time, in the this was going on in the UK, in Manitoba, another inquest was convened, again, under the auspices of a lawyer, Sinclair. And what they concluded their problem was too many centers doing not enough surgery and not doing it very well. There were a lot of other lessons from this, but that was probably the most important one. So they recommended regionalizing care, which the United Kingdom had already done. And what did that look like? Well, there are 5 centers, and those are the Western provinces in Canada, and I'll freely admit to being a moron about geography. I'm not sure I could tell you which of those is which. I'm pretty sure I could tell you which one's British Columbia, but the other ones I couldn't name. And if there are any Canadians in the room, I'll apologize for many things, including our president, but also that. So as a result of the reorganization, these 5 centers persist, but only 2 of them do heart surgery. And look at the geographic expanse here. So before that report came out, there were 4 places that were doing it. Now only 2. And the referral pattern's a little bizarre. If you're in Winnipeg, the habits are that you fly over Edmonton, which is the other surgical center, to Vancouver. So 1,450 miles. Think about that for follow-up postoperative care. And if you talk about access to care, which we're all concerned about, the idea that your nearest heart surgeon or your heart surgeon of record or your interventional cardiologist is 1,450 miles away is pretty daunting. But they managed to pull it off. And the results in Canada, not quite as good as the results in the UK, but better than ours. So how about the United States? Was anything happening here while this was going on there? We all, there are 3 countries separated by a common language. So yes, in fact, things were happening here. And so I've put a list of the things that I could find easily, beginning in 2001, importantly, after the 2 things that happened in Canada and the UK. So Denver, Seattle, Boston, University of Kentucky, Palm Beach, Tampa, North Carolina, reported in the New York Times, and then most recently at a smaller hospital in Denver. Each one of these is a result of a whistleblower calling a reporter or calling several reporters and you get this purple prose. The one from North Carolina was literally on the front page of the New York Times, and it says, "Doctors were alarmed. Would I let my own child have surgery here?" If you haven't read that and you're looking for something to upset you, it's easily found. So each one of these led to something, but the responses, unlike in the UK, unlike in Canada, were local. So the University of North Carolina had an internal problem. They got an external review. 4 people came in, reviewed the program, made some suggestions, and they enacted some changes, which were somewhat effective. Palm Beach, they closed the program. Tampa, there were some people fired, some people reassigned, they brought more people in, but everything was local. There was no national response, not even a regional response. So in the United States, we viewed these as local problems. And every 2 or 3 years, 4 years, it's been 3 years since I've seen one, something shows up in the press. Some nurse or doctor or perfusionist or ICU person or administrator has had enough. They've tried to fix things internally. It's not working. They call the newspaper and something happens. So we know about those. What we don't know about is when the same thing happens and there is some responsiveness and you get an external review. Now, I will tell you, I have been an external reviewer at 6 of these things. But as I'll tell you in a few minutes, I've also been reviewed. I've seen what this looks like from both sides, and I'll tell you it's very painful in both cases. But it keeps happening. It's like we don't learn. It's very frustrating. So here's the personal example. So I'll try to get through this quickly. This is a graph that our data folks, when I was in Dallas, produced for us. So the green squares are major surgical cases. The red squares, unfortunately, are children who died. I joined in 2017, January 2017, right above where it says month of surgery. And we had a fairly wholesale change in the surgical manpower contingent. There had been 3 surgeons, then they were down to 1 whose wife was delivering a baby, so he wasn't even operating. So you can see the volumes basically went in the toilet. When I got there, we started to build them back up. Things were going well, but then if you look carefully in 2019, 2020, you see a lot of red squares. Red squares are bad. Those are surgical deaths. This is where we had a problem, or we recognized we had a problem. We actually had a problem before that, and we hadn't recognized it. So what does that look like? So here's our operative mortality, looking backwards for 12 months and looking backwards for 4 years. So the smoothed out curve, which is the gray one with the yellow letters, takes some of the oscillation around the monthly. If you have a bad month, you don't want to contaminate all the other results. And so the curve is smoother, but you can see over time there were peaks and valleys. And then this is the peak here with an operative mortality rate for 1 year of 5%, which remember is 4 times what they have in the UK. That is awful. And that's what we had. So we recognized, I did belatedly, but others more quickly, that we had a problem. And so we requested an external review. And I called somebody that I thought was pretty smart, would come in as a surgeon. I also called a couple of other people, and one of the cardiologists that I worked with called some people. So we got a cardiologist, a surgeon, a transplant cardiologist, and a cardiac intensivist. Many of you in the room in the heart business will know all of these people. You can probably guess from the initials who they were. And they issued a report, which took, they were going to get it back to us in 2 weeks, which turned into 4 weeks, which turned into 6 weeks, which turned into 2 months. And there was nothing in that report that was surprising to me or the other people that were paying attention. The things that we thought should happen, we hadn't been able to make happen, but the external reviewers said that they should. So we thought, well, good. We've got external validation of the things that we knew that were wrong. We'll just fix those things. The administration will be responsive. They'll give us what we need. They'll change things, and it'll all get better. That doesn't happen quickly. Some of that involves personnel changes, and changing personnel is easy to do if somebody is standing there with a gun that has smoke coming out of the end of it, or has a chainsaw in their hand with blood dripping off it. But this isn't that. It's never that. And so the change takes a long time, and it is very painful while you're waiting for that to happen. So the things they talked to us about was restructuring, reassigning personnel, and putting better processes in place. They didn't say that we needed another surgeon, which I was happy about. Many of you who are involved in quality work will be familiar with the Donabedian model for evaluating and describing quality of care, structure, process, and outcomes. If you aren't, you will be. If you are and you're familiar with it, I'm sorry for putting it in front of you. I'm sure you're as tired of it as I am, except that it works. So it's a convenient way to think about things. So the importance of structure. I'm going to try to go through this, and the names should be small. If you see names, I apologize for this. I don't mean to embarrass anybody. This is what our heart center looked like from an org chart perspective when we had the problem. These are the things that needed to happen and did eventually happen. Those are people who were reassigned, promoted in some cases, astonishingly, but out of an area where they could do damage. But that's a structural change. So we changed our org chart. Process is something I'd like to spend a little bit more time on, but that is as important. So we had something, instituted something which in Dallas is called CMAP, in Milwaukee we call CCR, in Cincinnati and in Toronto, where it was first described, as called a flight plan. And basically what happens is that once a week, with backwards looking, graphically aided presentation, we talk about every kid who got surgery and say what happened to them. And everybody involved with every phase of care is required to make a comment. We did this, it went well, the team performance was good. And everybody in the heart center is invited to perform or to participate in this. And this is a screen capture from, we started doing it in June of 2020. This is a screen capture from one of the last months I was in Dallas. So at 4 o'clock on Wednesday afternoon, when virtually everybody would rather be someplace else via Zoom or now Teams, unfortunately, we had 104 people on. And that's not surgeons and cardiologists and ICU doctors. That's ICU nurses, physical therapists, occupational therapists, and those folks are, first of all, able to participate, encouraged to participate, begged to participate, but also able to see what's going on transparently. And somebody's keeping track of things that are identified as either good performance that we need to repeat or bad performance that we should prevent from happening again. This was culture changing, process changing, and it's something that I think was probably more than anything else most important in changing our course. The other thing that we did was instituted ad hoc meetings. And I joke with people, I'm not a Latin scholar. I think HOC is pronounced hoc. Other people think it's pronounced hoc. And if somebody wants to know why, I'll explain to you why that is afterwards. There's no Latins, no Romans around. We're all descendants in some form or other. But anyway, we call them ad hoc or ad hoc conferences. And what they are is mini cath conferences. We discuss every patient in our center, as you do here, who's going to have heart surgery before they have heart surgery at a regularly held weekly meeting. But irritatingly, sometimes children show up unexpectedly, and they should get the same consideration as children who are nice enough to schedule themselves electively. We weren't doing that. And it turns out when you rush things and change process, you do stupid things. And we were doing stupid things fairly regularly. A lot of times we got away with it, but sometimes we didn't. So now if you're going to the operating room without having been discussed, you're not going to the operating room unless you're actually getting CPR. And in Milwaukee, we do these same things. I don't know if you guys do here. I didn't ask. If you don't, you should. And then a lot of other stuff. I don't mean to dismiss this. PC4 and PAC3 are two wonderful organizations which have are well engaged in organizing and analyzing care delivered in the ICU and outside the ICU. And this is an example of a reduction in complications, failure to rescue. So one of the things that has been learned in congenital heart care is that the incidence of complications seems to be almost like Avogadro's number or pi. It's a constant. If you do things, you will have complications at a certain rate. The thing that distinguishes high-performing organizations from the alternative is what's your response to that? Can you rescue someone? So failure to rescue means you failed, and rescuing somebody gets you this. So you can see a dramatic change. This was led by another Josh, the good Josh, the one that didn't leave us, Josh Wolovitz in Dallas, and really astonishingly good work. We also started to monitor outcomes in real time instead of looking backwards every 3 months or once a year. Those of you in quality work will know the difference between common cause variation and special cause variation. Common cause variation is just random chance. Pardon my French. I don't think it's French, actually. Yeah, French. Merde happens. Shit happens. So that's common cause variation. Nothing you can do about that. Special cause variation is there's a process problem, or there's a structural problem, or there's a person problem, but it shouldn't happen. Common cause variation you can't do anything about. So to talk about surgical outcomes, this is a 10% mortality. You don't have to count them. I'll tell you, there are 10 reds, those are bad, out of 100 total. Blue is good here. So this is a 10% mortality rate that you could report in January looking backwards. This is a 10% mortality rate that you could report in January looking backwards. If up in the top left is January 1 and lower right is December 31, you have this, you have this, and you have this. All three show you 10% mortality rate. This is common cause variation. This probably isn't. This definitely isn't. But if you only look once a year, they all look the same and you miss a signal. So there's something called variable life adjusted display that some of you may know about. This comes from the insurance business and basically allows you to evaluate the frequency of bad outcomes in real time as each event happens. It's used in industry, particularly life insurance, but it can be used in any kind of process where you have a risk model that's predictive. So let's say that we do something that has a predicted risk of 10%. When you do one of those things, it either works or it doesn't. If it works and it's 100% successful, but it's predicted to fail 10% of the time. So if you're 100% successful, instead of 90% successful, you get 0.1 credit because you outperform the model, and it's put above the axis because above is better than below. So this is 10% better than predicted. So for that event, you get to move off the line of identity by 0.1, by 0.1, by 0.1. And then if you have somebody who dies, they were supposed to be 90% alive, but they're 100% dead. So you take a big dive. So this is a variable life adjusted display, and we can use this in surgery because we have predictive models. We know how often people are going to die if we do certain types of operations for certain types of conditions. So here is a variable life adjusted display, real data from Dallas. And on the left is a bunch of surgeons who started in Dallas over a period of about 15 years. This is the mortality rate for those surgeons in their first 90 open heart cases, the big ones requiring cardiopulmonary bypass. And what you see is that over the first 90 cases, basically everybody was still oscillating around the identity line. They were performing as predicted, but not better. If you looked at when we did this, if we looked at their most recent 50, they were continually getting better. So there's something different about what they were like for their first 90 than what they were like their last 50. Definitely they were older. Definitely they had more experience. But it's pretty unlikely that their facility with prolines and surgical instruments had somehow magically improved. Something about the system had gotten better. And what is that? I don't know what that is, but I think we can do better with onboarding people. And so what we did in Dallas, once we saw that graph, which showed us those kinds of things, was we did formal onboarding. So I hired 2 surgeons about 3 years before I left, 2 people that I knew to be good. One of them I had worked with when he was a trainee. I'm really excited to be able to recruit him. The other one was somebody that I'd heard wonderful things about, all of which proved to be true. These were 2 people that were very experienced, very talented, very good people, very hardworking. And I was afraid that they would be that last graph on the left when they came in. So when they came in, the first 10 cases they scrubbed, they got to stand opposite from me and watch me be brilliant. They did that not because I'm brilliant, but because they had to learn the system at a time when they weren't under pressure. And the next 10 cases that they did, I or my other senior partner scrubbed with them, no matter how easy the case was. If it was a PDA ligation, literally the easiest operation that we do, and we don't get to do it anymore because the cath lab guys are better at it than we are. But if it was that, we scrubbed with them. So the next 10 cases, so 20 cases before they're free and on their own, quite different than the way we used to do it. If somebody came in being able to do stuff, we just let them do it. And you saw what happened. And so these guys together on the right, that's their VLAB. See how they're not on the identity line? See how they went up right away? They outperformed. And you can see the impact on our mortality rate there as well. So this is a process improvement. So this is the peak I showed you before, the 5% mortality rate. And this is with what you're going to see next is with structural change, process change, and better analytics, better communication. That's what it looks like now. So we brought it back down. A lot of stuff went into that. Rather than just hoping things got better, being intentional, getting some outside advice, improving our processes, changing our structure. And that's where they are now. So this is something that the heart people may be aware of. Our professional organization, the largest umbrella organization, is called the Society of Thoracic Surgeons. And for about 30 years, most cardiac and thoracic surgical centers for adults and children in the United States have submitted a list of our operations with their outcomes to this Society of Thoracic Surgeons database. And in 2015, they began making publicly available this table, which is impenetrable if you don't know how to read it, and there's no reason that you should if you're not in the heart space. But what they do is categorize our operations, and there's hundreds of different kinds of operations into 5 categories. The higher the number, the more difficult the category is. The higher the number, the riskier things are. And they give us a report for each one of those mortality categories, 1 through 5, where they list the number of patients who got the operation and the number who died, so you can calculate a mortality rate. They also have a very sophisticated risk model that says what they think the mortality rate should have been, and they can therefore calculate an observed to expected with confidence intervals around it. So operation numbers, mortality rate actually calculated, what it should have been predicted, and then the O to E ratio. And if the O to E ratio is less than 1 and statistically different than 1, so if the upper bound of the confidence interval is less than 1, then you are a high performing center. And this is the report from Dallas as I was leaving. This is at the end of December of last year. On the right is what's called the adjusted mortality rate. That's if your performance was applied across the whole cohort of patients, all of the 40,000 people who, or 40,000 operations that were accomplished that year. And so in Dallas, the observed rate was 1.55. If they'd operated on what everybody else was operating on, it would have been even lower. So they were not risk averse. They were in fact risk avid. And that's one of the things that people worry about with this. So a lot of information here, but the boil down is at the top under O to E ratio, the overall observed to expected was 0.5. So half as many people died as would have been predicted, and that is statistically meaningful. The other thing that is unfortunate for me to have to admit, although there's both pride and some embarrassment, this is their most recent report. And if you look at the O to E ratio, when I left, they got better. So that's the real secret. Get me out of town. But I'm incredibly proud of this. This is hot off the presses from last week. So enough of the singular examples. How about a comprehensive look? I've told you about a bunch of individual centers. I've told you about one that I participated in. Here's a systematic look in the modern era. So one of the brightest people in our business is a woman named Sarah Pasquale, who's a data scientist and a pediatric cardiologist at the University of Michigan. She knows how to get down and into the granularity of all these data that are being submitted. And Sarah wrote this article in 2019. It was published in Circulation, our most prestigious journal, in 2020. And what she did was look at the operative mortality rate, sorry, OAR for anybody worried. She looked at the operative mortality rate for all of the centers providing data to the STS. And what she found was that the operative mortality rate between the highest decile and the lowest decile varied by a factor of 3. So that means that you might be 3 times more likely to die, depending on what your zip code is, getting the same operation. And initially, when she published this and I read the headline, I thought, well, that's all in high complexity cases, the one where the risk is high, the Norwood procedure or some other complicated biventricular, heroic undertaking where the operative mortality rate might be 15 or 20%. It's not. It's across all strata of complexity. So this is really worrisome. Variability is nice and interesting, and we're all unique. Everybody is a snowflake. Our fingerprints are unique. But our patients and their families should not expect that their risk for getting surgery in hospital A is 3 times higher than hospital B. If we go out to eat, we should get the same safe meal in all the places. We shouldn't get Montezuma's revenge or worse. So this is 6 years ago, so it's got to be better now, right? So I took the data that the Duke report, that the UT Southwestern report came from, and I don't have Sarah's level of sophistication, but I did the same thing. And I looked at the mortality rate, hot off the presses, like published last week, for all the centers in the United States that are above doing more than 75 cases a year. I isolated the small ones because their data have so much noise in them, it's hard to interpret the signal. And what we found is that exactly the same thing. So in 2026, what was true in 2020 and embarrassing and unacceptably true is still true. We have done nothing. This is a prettier picture than Sarah's. I was able to put color in here, put some greens, some red, some blue, but unfortunately, the picture might be pretty, that the data are very ugly. This is a map. Red performers are people that are performing well below what is predicted. Blue is as expected. Green is outperforming the model. So it's geographically scattered. There's no pattern. It's not that the people in New York are better than the people in Omaha or Phoenix or the converse. This is ubiquitous. It is a problem. There's not much to say here. There is a slight suggestion from this graph, which is the ODE ratio by volume. It suggests that if you're green and below the line of identity, statistically so, you're more likely to be at a high volume center. But one of the highest volume centers is a red dot above the 400 level there. That's a center I won't name. If somebody guesses it, I'll tell you afterwards which one it is. But it's a center that you all would be astonished to learn that they are doing what I would call shitty surgery, and they have been for quite a while. If you eliminate the smallest 75 programs, you still get the same thing. And it on the right here, better than expected 9 programs, as expected 68 programs, worse than expected 8. And this is eliminating the 15 smallest volume programs. That is a Gaussian distribution. If we took everybody's height by gender, we'd get the same thing. The question is, do we have to have a Gaussian distribution? If you think about the performance that I described in the United Kingdom, that is not Gaussian. It's not normally distributed. And I think we should strive to be not normally distributed. But here we are, normally distributed. Red is bad. This is an ODE ratio that's high, and the red ones are the ones that are statistically significantly high. And there's one where the ODE ratio is massive. So is there anything that we can do besides individual centers making themselves better or getting help in making themselves better? And can we scale this? And that's what Dan asked me to talk about. So I wanted to set that up a little bit. I said I wouldn't be political, but I couldn't help myself. There are many, many people in the room who probably don't know who this man is. He was once, he's an actor. Yes. He was once our president. It was a kinder, gentler time, or at least it seems to be now. I didn't feel like it at the time, but I thought this was a great line. And so I bastardized it a little bit. So as Dan said, I'm currently in a leadership position with the Congenital Heart Surgeon Society. And so we're here to help. You're welcome. So to go back to this thing that I showed before, the Donabedian triad, structure, process, outcome. I hope I persuaded you, at least in Dallas, that using that as a rubric was helpful. So the Congenital Heart Surgeon Society, at the urging of my late friend and colleague and the then president, Jim Tweddle, convened a group of people about 5 years ago now to try to come up with recommendations about structure and process, hoping to lead to better outcomes. And this was a typical type of a thing where Wednesdays and Thursday afternoons at 4 or 5 o'clock, everybody would get on a Zoom. It was one of the good things about the pandemic. If there's a good thing about the pandemic, is we learned how to use Zoom. And we set up a bunch of working groups with people from EP and people from quality and people from transplant and people from anesthesia and people from perfusion, all the components of a heart center, and asked each one of those working groups to come up with a set of recommendations for how cardiac centers ought to be organized, what their processes should be, and with the hypothesis that if these recommendations were enacted, that happiness would follow, and that we wouldn't have normally distributed performance, and that we wouldn't have the sorts of things that Sarah Pasquale described and I said are still going on. And as a result of that fairly mammoth undertaking, written by Carl Backer and Sarah Pasquale, whom I mentioned earlier, this article was published at JTCBS, one of our leading journals, Annals of Thoracic Surgery, another of our leading journals, and then the World Journal for Congenital Heart Surgery, another of our leading journals. We had a lot of leading journals. We have no shitty journals. And these recommendations were endorsed by everybody that we asked to endorse them, ranging from the American Academy of Pediatrics to the American Society of Echocardiography to everybody. great. We got a recommendations paper. The nice thing about publishing the same paper in 3 different journals is you get 3 lines on your CV. So duplicate publication turns out in this case to be legal. I hardly endorse it to all of your considerations if you're trying to make your CV look better. But I asked Open Evidence last night to prove that I can learn new techniques. How good is physician adherence to expert recommendations? It turns out not very good. In cardiovascular medicine, the Circulation, the Journal of the American College of Cardiology, quite frequently put out consensus recommendations, which are impenetrable. They're 50 pages long. Even if you wanted to read them, you could. And they've got this thing about level of evidence, 1A and 1B and 3.57D or whatever. It's really confusing. And so people just keep doing what they were doing before. That's a nice set of recommendations you got there. Your CV looks better, but we're just going to keep doing what we're doing. So here's our friend again, the president. And he actually didn't come up with this phrase, but it is often associated or credited to him. And this was in the context of a nuclear treaty with the then Soviet Union, which is what we used to call Russia. And what he said was, trust that they're going to do what they said, but verify. And again, I'm drifting off into politics, but the same thing happened with other countries. So the idea of the Congenital Heart Surgeon Society is that we trust that people will be following the recommendations, but we think we should verify that. And we learned about this from our friends at the American College of Surgeons, and specifically the pediatric surgeons, who did this about a decade ago, or began it about a decade ago under the leadership of Keith Oldham and several other people, some of whom may be in the room. But what they came up with was a set of recommendations for what centers delivering pediatric surgical care to children should have in place. And they trialed it at a bunch of centers. They iterated on it. The process is improving. And I can tell you, they came to Dallas when I was there. I'm sure they've been here. And they inspected us. And they came through with a fine-tooth comb. It's like JCO, only writ smaller, but it creates the same level of anxiety in administrators, which is very entertaining to watch. But they came to me and said, we see that you don't put progress notes in the chart on your patients every day. I'm like, I haven't written a progress note since we used ink and pen. They thought that was a bad idea, and they're probably right. I don't know if they are or not, but we changed our processes, and a lot of other more substantive things happened. So we thought this was a good thing, and we've modeled our project on that. So there's a whole bunch of other areas where verification or certification is done. And in cardiovascular medicine and surgery, these are a list of some of those, and I'm sure I've left a lot out. So I asked a group of people to get involved, to form a task force to do this. And I asked Joe Deraney from Mayo Clinic and David Overman, who's my predecessor as the 2 most recent past presidents, to lead this. And we tried to get a group of people on this task force who were representatives. So we didn't want to just have big centers because the smaller centers wanted to be heard from. And we didn't want to just have people from the upper Midwest, although 3 of us are now from the upper Midwest. So this is a list of 9 people from various parts of the country, from centers of all sizes, ranging from huge to not huge, in fact, to tiny. And like with the other project, we started meeting a few months ago, Thursday nights, unless somebody has dinner or forgets about it. And we put together the same sorts of working groups. Many in the room will recognize Mitch Cohen's name, for example, but there are people that are experts in their content areas. Some of these were the people that led the prior groups. And then within each of these groups, and I believe there's some people from here involved, we asked these folks to come up with a set of enforceable, evaluable recommendations for what should happen. And so we are working forward with a timeline, which is fairly ambitious, that we will have something ready to put in place by the end of this year. I don't know if that's going to be achievable or not, but we have been working on it. So coming soon to a center near you like this one, somebody who's going to call Dan up and say, hey, do you want to be certified by the CHSS? And he, of course, is going to say yes. And so we're going to say, well, we'll see you in a couple of weeks. We're going to come out and visit you. We think it'll be about 2 days. We'll send a list of what you're going to be evaluated for probably 6 months before. So you can look and say, before they get here, we need to put this in place. It'll be facility tours. We'll look at data and charts. We'll interview people, and then we'll convene a group of us that were there. And we'll say you passed or you didn't pass, And if you didn't pass, here's what you need to do to pass. Now, one of the things that we've talked a lot about on the task force and at the CHSS is to go back to the iceberg diagram I showed where people solicit external reviews. That never happens until there's a problem, with one exception, actually. I'm just about to go visit a center who's got things that seem to be going really well. They said, hey, why don't you come see us when we're doing well? This is not meant to be punitive. It's not meant to be restrictive. It's actually meant to be helpful. So if we send a survey, once we get that survey put in place, that's a pre-visit survey, we mean to point out to you things that we think you may not have in place, and we mean you to have that in your hands so that you can go to the C-suite and say, I really do need another data analyst, or we're short one electrophysiologist, or our ICU has something that they shouldn't have. And if we find that there is a problem, or you find that there's a problem, we want to be helpful in that. The goal here is not to have a pass rate of 90%. The goal here is to have a pass rate of 100%. And the goal here is not to have a Gaussian distribution of performance. The goal here, like Lake Wobegon, is to have everybody performing at high level, as our friends in the United Kingdom has shown us is possible. There's a lot of other stuff that we have to get in place before this is actually underway, but I'm optimistic that we can get this done. I think we have to get this done. There's a burning platform here that we haven't been paying attention to. And when you set aside graphs and pictures and diagrams and slideshows, what we're talking about is avoidable, preventable morbidity and mortality that everybody wants to avoid and prevent, but we can't get out of our own way to do it, and we need to start being more thoughtful about it. People in the room, again, that do quality work know what a PDSA cycle is: plan, do, study, act. It's a circle. You identify a problem, you analyze the problem, you come up with a plan to address the problem, you address the problem, and then you see if it worked. It's a circle. In quality work and in cardiovascular medicine, we've been really good at studying. I can show you a lot of other graphs that are really cool that show you that our performance is shitty. We need to stop doing that alone and take the next step, which is to intervene. One of my favorite sayings, and I can't remember who said it, is we need to stop staring up the steps and start stepping up the stairs. And so that's the goal here. So that is not all I have to say, but that's all I'm going to say. Okay. Let's see. I'm supposed to get to the QR code at the end, so everybody gets a discount on today's activity. All right. With that said, I will actually shut up now and be happy to entertain any questions, or happy to believe that I've told you everything you wanted to know and more. Thanks.
Thank you so much for this presentation. Hope people here up there kind of get organized for their questions. A couple comments first. Kind of similar input when the PIPS people came around, August notes. Hopefully it looks like we've fixed that problem. I am very relieved that you didn't joke at how changing our color dot on the map and left it blue. So thank you for that. But I do want to say thank you for, to the task force and the group for inviting us. We are part of that group. I mean, Jordan, our chief perfusionist, is part of the perfusion subgroup. I'm part of the surgical subgroup, and we definitely are interested in volunteering to be in the first batch that goes through the certification. I think this is very important. I think it screams collaboration, and taking the barriers from old school behavior. It's a good thing. I do have one question about the UK. I did spend some time there, and I know that they are very focused on resource allocation and doing what statistically is beneficial. I mean, do you see a difference? Do you see that being a reason why their mortality is 1% and ours is double? Are we doing things that we shouldn't be doing? Which I tend to, I know the answer to that, but I'll let you expand. And I'll share with you that we shared details yesterday about how we've gone about reducing that, creating, a high risk group, trying to do the right thing, and understanding that there are times we are going to do hard things that may not necessarily be, but I'll let you answer.
So the question about whether we're doing things that we shouldn't be doing, the answer to that is yes. There are centers and days in centers when decisions are made that external people who are not uninterested but disinterested, who are unbiased, would say don't do or do something different. Some of that is surgical hubris. Some of that is simple and understandable but unforgivable ignorance. People don't know things that they don't know, but that they should. Some of it is sometimes driven by more venal motives than that. The arrangement and delivery of healthcare in cardiac patients and in cardiac systems in the United States is absolutely nuts. So, for example, San Antonio, which is not a small city, but not a huge city either, has 3 cardiac surgical programs. There is no justification for that in any rational way. The UK doesn't do that. There are a couple of programs in London. They're both huge and they're both performing at a very high level. That's nuts. Some of you have spent time, very formative time, I would think, at the Texas Medical Center. At the Texas Medical Center, not only are there multiple adult hospitals, there are 2 children's hospitals. That is nuts. Both of them have transplant programs. That is nuts. Why do people do things that are nuts? If I knew the answer to that, I wouldn't be doing this. But there are people doing things that they shouldn't do. And if we don't start calling them out on it and presenting them with a different way to do things, they'll keep doing stupid things. They may keep doing stupid things anyway. We seem to have an inexhaustible ability to do that. I have lots of quotes. One of my favorite quotes, though, about this context, and it gives me hope, and this is probably wrongly credited to Churchill. He said that Americans can be counted on to do the right thing as soon as they've exhausted all other alternatives. I think we may be at that point. And then the resource question is, this is an incredibly resource heavy undertaking, and in areas where resources are constrained, either by virtue of governments that are poor or hospitals that are poor, or administrators who are inappropriately constraining resources, outcomes are impacted. So we can help with that and say you can't do this if you don't have these resources. But anyway, gosh.
Hey, great talk. I appreciate you coming, and that was really good. I have a question about the last slide with the graph, and I love the idea of getting certified and bringing the water up to 100%. What I'm worried about is what if the right side of that graph, 90% of those centers who are pretty close to that median are the ones who sign up and said, yeah, and they all get a little bit better, and you make them all 100%. I'm worried, and you just said it, people do stupid things. What about the other 10% who said, yeah, I'm not going to sign up for that because I'm going to keep doing surgery because you can't stop me?
Yeah, well, in the United States, we can't.
Right.
In the UK, they not only can, they do. In Canada, they stop people from doing things. We can't do anything about that, unfortunately. America. I mean, where this is when I moved to Texas, I took a picture of the sign outside the hotel that I was staying in until our house was ready. It says, although you are allowed to carry guns in Texas wherever you want, please don't bring them into the lobby. It's not a world that I really was happy with, but there's a hell of a lot I can do about it. So you are right. Some people are going to keep doing stupid things. The best we can do is call it out when we see it. I'm a believer, again, another quote, assume good intent. If somebody's doing something stupid, it is possible, it may not be true, but I can imagine a possibility that they're doing it because they don't know any better. So at the CHSS, at least we can help you know better. Whether you persist with that or not, I don't know. Another quote, I got lots of them. During the McCarthy hearings, nobody in the room is old enough to remember the McCarthy hearing. During the McCarthy hearings, during the Red Scare, when it was assumed to be a communist under every rock, which seems to be resurfacing, there was a question by a senator, and he looked over at McCarthy, or it wasn't by a senator, it was by the guy at Welch being grilled by McCarthy. He looked at McCarthy and he said, "At long last, sir, have you no decency?" So at the end of the day, most people want to do the right thing most of the time. So the more light that we can bring to this, and the more that we can make it easier and facile to do the right thing, the more likely it is that people will do the right thing. but we're all fallible, and sometimes people just do bad things. So, long answer. Done.
There was one question online. Why is the denominator congenital heart surgery in capital rather than congenital heart disease in capital? Any center can get their mortality down if they let the most challenging patients die. That's not an improvement in care.
A couple of different questions, excellent points. I put congenital heart surgery in because it's the thing that we can measure. It's the thing we have the data for. You know, somebody can die as a result of getting poor care without ever having or needing surgery, but if they get the wrong medication, or if they don't get they don't get cardioverted when they should, or if they don't have a pacemaker put in when they should, if they're not on the right medication. We just don't have data for that. It's not as public, and it's not as likely to be lethal as a badly performed or ill-performed surgery. The second question about high-risk patients is very important. And so in 2015, when the Society of Thoracic Surgeons made it possible for institutions to report their outcomes publicly in an audited and verified way, about 15 programs out of the 100 or so who could decided they would do that. And then everybody else slowly dipped their feet in the water. And now we all do it. And one of the concerns that was raised was if we start having to tell people about bad things and we take on a high-risk patient and it doesn't go well, that's going to make us look bad. So we're not going to do that. And so a woman named Brett Anderson, who used to be at Columbia, is now, I believe, at Sinai, but is in New York City, brilliant woman, who's a pediatric cardiologist, but also like Sarah Pasquale, a data wizard, looked to see what was happening over that period of time. So when public reporting became possible, she had data from what centers were doing before they began to publicly report and what they were doing after they publicly. And so what you would expect is that people were influenced by the fact that they were going to have to open the blinds and show everybody what's going on inside the sausage factory. They didn't want to do that if they were doing bad stuff, so they'd start sending high-risk patients away or simply not intervening on them. That turned out not to be the case. The same risk or the same concept was seen in adult cardiac surgery. New York State began reporting outcomes for adult cardiac surgery about 20 years ago. And the thought was that all the high-risk patients were going to get shunted out of the state and they'd all go to the Cleveland Clinic. The Cleveland Clinic had and has plenty of work, but they didn't get any work from that. So that's a very reasonable thought, but it turns out not to have been the case. Now, I'm sure there are times, and I'll tell you, frankly, there are times when we think about case. You know, if you ask a parent, if you said to a parent, there's a 1 in 10,000 chance that your child will survive this. If we don't do it, the child has no chance. Every parent would say yes. But the truth is that undertaking for the, I forget whether I use 10,000 or 100,000, but the nines, the people that don't survive, that's not cost-free. It's not cost-free for anybody. It's not cost-free for the surgeon who does the operation or the interventional catheter doctor who does the procedure that doesn't go well. It's not cost-free for the patient in the next bed who gets to watch somebody die. It's not cost-free for the nurse who does that. It's not cost-free for the reputation of the hospital. So unfortunately, sometimes we have to say that if something is very unlikely to succeed and is 100% guaranteed to cause misery for many people, we won't do it. So that's a moving target, but it is something that you have to pay a great deal of attention to. And I will say that one of the things that I'm very pleased to take away from my visit here is the process that I learned about yesterday that you guys have established, you being Phoenix Children's Hospital, for patients in whom you decide not to offer care, that you don't do that arbitrarily as a one-off by 1 or 2 physicians or nurse practitioners or people who say, oh, we're not doing this because it's too high risk. There's actual formalized process which mandates the solicitation of an external opinion. That's one of the ways to guard against excessive risk aversion, but it is a risk.
You know, Josh, to your point about the right side of the curve, all of those are people who are publicly reporting. So I tend to think that number of those who will say no to joining will be very small and pretty soon singled out, and hopefully peer pressure. I don't think it'll get to 0, but I think it'll get closer to 0, probably less than that.
The dark web is probably never going to go away.
Yeah.
Kevin.
You comment on the role of, simulation and dealing with these critical, unavoidable situations. And this institution has spent a lot of time, upfront doing, pre-briefs and timeouts and, marking and all that stuff. And, that's important, but events do occur. And maybe I trained at one of those high volume shitty centers where we had lots of events, but, I did it in Boston 25 years ago. And every month at the CVICU, I would be doing CPR at least 5 times. And I think a lot of the younger people here don't get that hands-on experience. And it's like, training pilots. A commercial pilot should never have to do, an emergency landing with both engines out, but yet they know how to do it because they've practiced it. And I think we're a little bit lacking on exposing our young, not only physicians, but, nurses and staff to infrequent for critical situations where, that is an opportunity to rescue. I got more experience doing pericardiocentesis in an animal lab than unfortunately I ever did in the cath lab. And, to acquire those skills is difficult. So how important is simulation for rare critical events that most people fortunately don't encounter?
I will tell you freely, I am not an expert in this, but I think your points are all well taken. Every place that I've been is somewhere along the line of developing more and more sophisticated simulation. I think one of the things that made the reference to the aviation industry, which we do frequently and always, not always appropriately, but I think one of the things that strikes me is that decision-making under pressure is something that I struggle to see how we get to that. I think making decisions when you have a circulating level of catecholamines that's very high and making those decisions in an appropriate way. I don't know how you can quite simulate that, but if your simulation system, looks at statistically what is likely to happen, what are you likely to see, and puts in place an algorithm for what you do then, which is what pilots do. If the engine 3 goes out, this is what you do. And you practice that, we could do a much better job of that. The other thing that you talked about, which is not exactly simulation, but is a little bit related, which is anticipating bad things, which is the surgical timeout or the surgical checklist or the surgical briefing. Both where I am now and where I was most recently, one of the more complicated undertakings we handle from a logistic point of view is a transplant operation, because there's a lot of coordination that has to happen and some timing issues that are very important. But also it happens at night. And so we started doing briefings before transplants, and I think many people do that. When I was a much younger surgeon, I would occasionally get very irritated in the middle of the case because they didn't have what I needed. How can you not have this suture, which is obvious to anyone who knows about it that I would need? Why don't you have that patch? Why isn't it open? Why do I have to wait? Well, it turns out that almost no one that I've ever worked with is a telepath. And I hadn't told them that I might need it, even though I knew I might need it. In fact, I was confident I was going to need it. So I started sending out an email the night before that said, this is what I'm going to need. And now people say, why didn't you send out the email last night? Why did you get up and do it at 4:30 this morning? I'm sorry. But there's a lot of stuff that we can do about that. Instead of just assuming and that people are going to know what to do when the kid does what it looks like he's going to do, which is arrest. Why don't we train them how to do that? If we can do it on an animal lab or on a resuscitation dummy that's got maybe better than the one in the office, but that's got the physiologic feedback, I think that's great. It's not an area that I'm expert in. It turns out to be most of the world. So, Kevin.
Thanks for that, Jake. I wanted to ask about the process of the certification visits and the thoughts you're getting from sites. The backer paper seems that some sites should not be comprehensive. But I imagine that's kind of a sense of loss for sites that you visit and tell them you probably shouldn't be comprehensive. You should probably partner with another station. And how much are you hearing any sense of places saying, I want to be a supplementary site, not a comprehensive site? And how much is that impacted by sort of mainly revenue?
Sure. So the question has to do with classification of sites and who should be doing what. And when the paper was written, the backer paper, we suggested that there should be 2 types of centers, one called essential centers, which did the basic stuff, and one called a comprehensive center, which did everything, transplants and all the sophisticated stuff. We also put in a volume suggestion that ranging somewhere around 200. If you were above 200, you could be comprehensive. And if you were below 200, you couldn't. It turns out that a lot of feelings were very hurt about that. A lot of centers were not happy. Center that was doing 199 and doing everything and doing it well was being discriminated against. And they didn't care for that. And in fact, some people that are very good friends of mine called me up and said, you guys are basically restraining trade. This is a poorly disguised attempt by big centers to dominate small centers, and it's unacceptable. And so my response to that guy was, thanks for volunteering to be on the task force. But one of the things that we did seriously was we took the volume requirement out. And we eliminated the distinction between comprehensive and essential centers. And what that did was it changed the group of people who are pissed off from the smaller centers to the larger centers. A very good friend of mine, who's going to be my successor as the president of Congenital Heart Surgery Society, said, this is bullshit. You can't let these programs that are doing 125 cases a year call themselves comprehensive. So it turns out, and I had never realized this before in my life, you can't please everybody. And so what we have done is said, you're either certified or you're not. We didn't eliminate numbers entirely. There are very good and defensible statistical reasons to make the cut at 75 cases per year. And everybody agrees with that, except for the centers that are doing less than 75 cases a year. But we had to draw the line somewhere. So that's an answer.
We are at time. Thank you very much for presenting today.